Palliative care is the medical subspecialty that treats the symptoms and stresses of serious illness. Over 50 million Americans have been diagnosed with COVID-19 since the pandemic began, and by definition, those who have been hospitalized were seriously ill. Therefore, the skills that palliative care clinicians use every day, support for priority testing, listening, communication, and symptom management for complex needs, are the same skills that have been in high demand in hospitals throughout the U.S. during the pandemic. But what are the lessons learned, and what does this increased awareness mean for hospitals in the future? Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hetterly with AHA Communications. In this podcast, the AHA and the Center to Advance Palliative Care, or CAPC, are brought together by the AHA's Living Learning Network. That's a CDC-funded peer-to-peer community of healthcare professionals dedicated to helping hospitals and health systems recover, rebuild, and reimagine the future of care. The following is the second and final episode in this series, recorded during a live virtual event held in November 2021. Hosted by AHA's Vice President of Clinical Quality, Marie Cleary-Fishman, the esteemed group of panelists includes CAPC CEO Brynn Bowman, AHA's EVP and COO Michelle Hood, Medical Director of Palliative Services and Associate Professor of Medicine at Virginia Commonwealth University Dr. Danielle Noreika, and Professor and Chair of the Brookdale Department of Geriatrics and Palliative Medicine at Mount Sinai, Dr. R. Sean Morrison.
So I'd like to move on to our next set of questions. And this is really around stories from the field. So Brynn and Dr. Morrison, I think we're going to direct these questions to you. Do you feel palliative care teams were deployed in any new or different way during the pandemic? If so, how? And then can you share some examples of clinical collaboration and palliative care integration that you saw in the field during COVID-19? Brynn, do you want to start us off?
Sure. I'm happy to cite a couple of examples, and then I'm really excited to hear about what Dr. Morrison has done at Mount Sinai. And in full disclosure, CAPC is affiliated with Mount Sinai, so we are close colleagues, and I had a front row seat to all of the incredible work that his teams were doing. But I wanted to pick up on a thread that Danny mentioned, which is all of the gaps in care for very sick patients that have been exposed during the pandemic. And a couple of examples of innovation that we saw that I think really specifically address gaps that we know we're still going to have to solve for when we feel like we're out of the woods of the pandemic. And one is care in the home for patients who are ill but not in the hospital and may have a hard time making it to appointments, or maybe may have a high level of need. And one example of what happened during the pandemic was I was speaking with the system lead for palliative care at MedStar last week. And they'd put in place a program just before COVID really hit, and then dramatically ramped it up as soon as the pandemic did hit. And they shipped remote monitoring devices into patients' homes. Inpatient palliative care staff were the people who would do weekly telehealth rounding with an interdisciplinary team with those patients. And those patients all had 24/7 access to a palliative care specialist if there was a crisis in the middle of the night and they weren't sure whether they should be calling 911 or taking that medication. By using that inpatient staff and having everybody swing between the two scenarios, there was continuity for patients following a hospital episode, and those early crises were averted. So I think that's something that, again, when the rules of the game have been thrown out the window to an extent in the last year and a half, and especially in the early days, there's something instructive about the pivots that palliative care teams were making. Another example that I find fascinating and have thought a lot about what would it mean to scale it around the country is that Penn stood up a virtual nursing home palliative care program. So talking about new collaboration and new use of telehealth in a nursing home whose residents would go to Penn if they needed to be hospitalized and who were dealing with COVID, of course, during the last year and a half, and whose clinicians had their hair on fire, clinical staff at all times. They were able to make a partnership where palliative care providers were providing telehealth visits to sick patients and talking about their goals of care, communicating with family members, and making sure that everybody was in the loop about the resident's clinical scenario. And that's something that I think is hard to, because of financial pressures and parameters, is hard to expand in all areas. But I think in certain health systems where the relationships between those SNFs and the hospitals is such that could be expanded, and there's so much need among that patient population. And then the third example that's coming to mind is actually a different perspective on this story, but I mentioned at the top of the hour that CAPC provides clinical education and core palliative care skills for clinicians who are not palliative care specialists. We do that online in self-study courses, and in March and April of last year alone, 50,000 courses from that palliative care curriculum were used. And what we saw was, if you'd been in New York City or Washington during those early months, did you have time to sit down and take a course? Absolutely not. But the people who were taking those courses were from other areas of the country and were realizing, wow, I'm really going to need to think about managing shortness of breath, going to need to think about how to hold a family meeting, going to need to think about what a caregiver on the other end of the phone line is going to be thinking and expecting to hear. And so we're taking those courses in preparation of hitting their own surges. Similarly, we had the example that I'm thinking of was a resource that was available for download on our website, and it was a pocket card for clinicians that had crisis prescribing protocols for dyspnea, for shortness of breath, and then had key phrases for patients who came into the emergency department about what were their goals and what was the appropriate next step to admit that patient, to see if that patient were able to return home. And those pocket cards were downloaded by the tens of thousands. Thinking again about the gaps in normal times, I think that shows that healthcare workers themselves were realizing that they had gaps in training, gaps in education around those skills that they really needed to have during the pandemic. So I hope that we keep thinking that way about what it means for everybody to care for patients with serious illness as we come out of this, and what support that requires for clinicians in the form of education, but also in the form of the supportive infrastructure to use those skills.
Thank you, Brynn. 50,000 courses, that's pretty amazing. That's a lot of interest out there. Great to hear that. Dr. Morrison?
Yeah, thanks, Maria. Thank you again for having me on this panel. I want to talk really about three things. The first is a little bit about COVID in New York and our health system. And as Ms. Bowman said, what were the adaptations that were made? The second is really what have we learned from that, and what's the importance to the field moving forward? And then finally, what are the programs that have continued and I think are really good models? And many of you were fortunate enough not to be in New York City on March 1, but let me sort of describe what the situation was. March 1 was when the first patient with COVID actually presented in New York City and presented to our emergency department. So in fact, we were ground zero for COVID in New York City. We're a large health system. We have 2 100-bed community hospitals. We have 3 large, mid-sized 350-bed hospitals, tertiary care centers. We've got a third community-based hospital of around 200 beds, and we've got a large academic quaternary care medical center. All told, we have across the health system somewhere in the order of 3,000 beds and 283 beds. And on April 11th, in the midst of the surge in New York City, 2,000 of those 3,000 beds were taken by people with COVID-19. So 2/3 of our beds were devoted to COVID. And we had somewhere on the order of 485 people in critical care. And remember, our capacity pre-COVID was 283 ICU beds. So what we were facing was really 3 key challenges. The first was critical care operating at about 1.5 to 2 times normal capacity, and all of the workforce shortages that went along with that. Emergency departments that were completely overwhelmed, and I think many of you have seen the pictures of tents in parking lots where people were standing. That was our hospitals. And the third is hospital services that were also completely overwhelmed. And in fact, we deployed all of our non-internists in the health system to those hospital services, emergency physicians. So we had pathologists, dermatologists working on those systems. So what was the role that palliative care played during that, and where was the integration most effective? Really in four key areas. The first is very early in the pandemic, we inserted a palliative care clinician into all of our emergency departments. And the reason for that was threefold. The first is that the symptom burden of this disease was extensive. Everybody was breathless, very breathless. Many had delirium and were confused, and all of them were isolated and scared because they had no family members. And what our teams in the emergency department were able to do was handle all the symptom management so that our emergency physicians could move from one critically ill person to another, intubate those who needed intubation, and essentially provide the critical care that they needed while our teams both contacted families, discussed goals of care with patients, and managed symptoms. And it was able to spread an emergency physician workforce much more broadly than could have been possible without those teams. The second place that our teams were inserted was in with all of our critical care units. And again, we deployed clinicians as part of our ICU teams. And in that role, they didn't do what ICU physicians couldn't do. But what they did was, again, very important goals of care discussions and very aggressive symptom management, which allowed our intensivists basically to look after the vents, the ventilators, to manage the blood pressure. And again, it allowed that added layer of support allowed us to make the best of a limited workforce. The third area was within our hospitals teams. Again, providing that added layer of support around goals of care communication and around symptom management. And as Brynn said, in an ideal world, we would have been able to train people and give them cue cards and on-the-spot training. The reality is we couldn't do that because of the speed of which COVID hit New York City. And then Danny talked a little bit about the home care and telehealth, because for many people, and particularly those living with serious illness at home, the hospital was the absolute worst place to be during the pandemic. A, we didn't have any beds. And B, if you're immunocompromised, the last thing you want to do is be in a situation where COVID is rampant. And what we did was we took a research program that was developing a new model of community-based palliative care where the front line were specially trained community health workers, backed up by social workers and nurses, and then backed up by a nurse practitioner and clinician, and essentially scaled that to the health system very, very quickly. We were able to partner with our pharmacy so that we could deliver medications to the doorstep within 2 hours of needing them. And with those medications was PPE so that family workers were protected, given the fact that we didn't have any home health aides to move forward. And we also invoked telehealth for both goals of care conversations and symptom management. And I don't think it's an understatement, and certainly the leadership of our health system recognized that we were one of the four key services that brought us through COVID, along with our hospitals team, our ICU team, and our emergency physicians. And so what are the lessons from that moving forward? Well, there are a number of models that have stayed absolutely in place. Our integrated ICU teams, which we had a small number before, are now in all of our intensive care units in the health system. Again, because it allows us to increase capacity and allows our intensivists to do what they do best and our palliative care teams to do what they do best. Our emergency physicians have requested palliative care in the ED, both in terms of conducting goals of care discussions right up front, but also in terms of symptom management. Our home-based palliative care is now rolling out across the entire health system. And so that went from a small research program to a fully fledged program that is now in all of New York City, Lower Westchester, Western Long Island, and a little bit in Eastern New Jersey. And telehealth was interesting. We learned a lot about telehealth. We learned that telehealth was really good for crisis communication. And it wasn't really great for long-term or ongoing needs. It was really good for symptom management, but it wasn't great for ongoing goals of care discussions or connecting with families. It was terrific in terms of bringing families in to be with patients in an absolute crisis setting. But the moment that the hospital opened and the moment the visitors were allowed, it was second best. And our families recognized that very, very quickly and asked for presence rather than simply being on a screen. That, as I said, during the crisis, it was effective. Post-crisis, it wasn't terribly effective. And then finally, I think what we learned, and this comes back to points made earlier, was that moving forward into the future, the absolute critical need for every clinician to have core palliative care knowledge and skills. Because we survived, the sprint. We managed to get through the marathon, which was up until the vaccine. And yet this is a journey that we're going to be on for a very long time. And our teams now are just exhausted. And my faculty is just exhausted. And it's just not a sustainable solution to providing the quality of care that people with serious illness both need and deserve. And so we have to have a different approach than specialist level palliative care for everybody.
Well, thank you so much, Dr. Morrison. That is really insightful, and I love the points. And I think we'll see a location of care where you inserted that the ED, critical care, hospitals, teams, and then home telehealth. And I think you'll see later in some of the questions that were submitted in advance, those are definitely the areas people have questions and are thinking about. And so, while that may seem logical, it's consistent with what we're hearing and the kinds of interest we're seeing in the field. Really, really great information. I'd like to move on just to keep us moving, and then we can circle back to some of these issues and the questions we have later. We'll go on to the next question, which is around age-friendly. And I'd just like to take a minute to share the age-friendly work that the American Hospital Association is doing. We are partnered with the John A. Hartford Foundation, who funds this work, the Institute for Healthcare Improvement, and the Catholic Health Association in doing work around age-friendly. And age-friendly has some very overlapping areas, similar concepts with palliative care. And I think there's a beautiful synergy between the two, and you'll see that as I just very briefly go over the model. And the model is something called the 4 M's. But it starts out with a what matters conversation. And I think that's something that's really common to palliative care as well. But then it looks at medication, mobility, and mentation. But all of those things are looked at in concert, connected, and also through that lens of what matters. So you never pull the M's apart and only look at medication for someone. You look at what their goals are, what's important. And for those of you who might have come across me earlier in age-friendly work, you know that whether my dad likes it or not, he's my model frequently. And I say that I live age-friendly care every day at home, because what matters to my 90-year-old dad is the ability to get to my niece's volleyball games. She's a senior in high school, and they are moving through the different levels and had a big win last night. And his need to get to those games is critical. So I look at that, what matters, and then I look at what are the things that impact his mobility? What are the things that impact medication? Is that having an impact on his mobility or his mentation? So we look at those things together. But I think it really overlaps and connects with palliative care and that what matters conversation. And I love the fact that you're pulling palliative care into those areas in order to have those goals of care conversations, but really to try to bring them down to what matters. Because if you were to approach my 90-year-old dad at this point and say, what are your goals of care? He'd probably look at you a little funny, but he would very, very quickly and very clearly tell you that if he can't get out of his chair and he can't cut his lawn on his riding mower, and he can't get to those volleyball games, then it's a done deal for him. He's very, very clear about what's important to him. And so I think that we look at this, and I'd just like to get some insight from both Dr. Noreika and Dr. Morrison around how you might see palliative care as a component of age-friendly capacity for hospitals and health systems, how you see those pieces together. You've touched on a few things in your other comments, but anything else you'd like to add about how the work might integrate and help hospitals and health systems with that longitudinal care that Michelle described earlier?
I'm chair of the Department of Geriatrics and Palliative Medicine. And there's a reason that those two quote unquote specialties are under one umbrella at Mount Sinai and throughout the health system. And the reason is simply about demographics. When we look at the population in 2030, for the first time in all of human history, the number of people over the age of 65 is going to be greater than the number of people under age 18. We have never seen that ever. And the entire time human beings have been on the planet. And when we look at older adults and we look at an aging population, most people are going to live beyond the age of 65 for 10, 20, 25 years. And most of that time is going to be spent in good health. And they're going to need, some help, but most of that time is going to be spent in good health. Yet almost all of us are going to develop one or more serious chronic illnesses, multimorbidity, that we're going to live with for a very long time. And that group of people with serious illness is the center of the overlapping Venn diagrams of geriatrics and palliative care. It is the group that has going to have the most clinical needs. It's certainly the most expensive group for our healthcare systems. And it's a group of individuals for whom, if we combine all the geriatricians and all the palliative medicine physicians in the country, we will still not have enough to care for. And so I think what we need to do is think beyond specialties and start thinking about what are the needs of the population. And the needs of the population are going to be age-friendly health systems, because that's who's going to be using them. When we built our hospitals and created Medicare in 1965, serious chronic illness didn't exist. You were diagnosed with a serious illness and you died pretty quickly. And that is our infrastructure. And that is not the population of today. So we need a healthcare system that matches the needs of the population. We need a healthcare workforce that is going to target the most vulnerable, the sickest, and the most expensive populations. And that's where I think geriatrics and palliative care need to come together, because that's the population that's going to need our care both now and in the future. And I think we've got to start thinking about them as separate.
Thank you. Dr. Noreika?
So very, very much agree. I had the amazing opportunity actually over the course of the pandemic to participate in AHA's Next Generation Leaders Fellowship. And nobody told me to bring this up, by the way. It was an awesome experience. It is incredible that they were able to pull it off during the pandemic when everything was wrong. They were completely committed to our learning and doing it in the most flexible manner possible. So I have a lot of thanks for Christine, Chris, and their team. And certainly, please feel free to reach out to me offline. I'm sure we can make my email address available. I have talked to other folks who are interested. I'd love to tell you about it. But one of the great parts about that for me was I had not interacted quite as much with the age-friendly health system model. And certainly folks who kind of were focusing, all of their time, they were here because they were doing projects solely in that age-friendly model. And I think it was a great experience for me to get to sort of work with folks. Marie, you mentioned a synergy, and it was just a natural synergy. It's like, you're one of my people, because it was like, yes, these things are important. This is who the humans we take care of are, and it's important that we focus on these things, and we're going to have to do a little bit of work to sort of pull everybody else along the bandwagon, but we're going to, because it's important. And I think it also helps, there's obviously a lot of misperceptions of palliative care. We're all aware of that. And I think one of the things that I love about partnering on something like the 4Ms is that it sort of it sort of gets at what folks misperceive about what we do sometimes. So if I'm a palliative specialist and I go in and I say, we're going to manage the pain, we're going to, balance the medications we use so that we're maximizing function, minimizing side effects. I need to know what they're doing. I need to know how often they're awake. I need to know what they're eating and all these things. And everybody's like, you're palliative, you just give them some opioids and, you call it a day. And it's like, no, that does not help a patient's quality of life, right? That's what I'm here for. And quality of life is all of the things that you mentioned about your families at the beginning. Goodness knows that it will never be on my life plan to do a riding mower ever. But I'm like thrilled that, your 90-year-old dad is like, this is a thing. I'm going to do this. And if I can't, we know what the plan is from there. So how do we, all of those things are part of patient goals. Every time I say patient goals, I have colleagues here who come up with code status and dialysis and whether or not we're going to intubate them. That's part of why we have some trust issues, right? We bring up goals, we start talking about interventions. The humans are humans and they want to be humans and they should be. So how do we change the language? How do we change the approach so that when my colleagues walk in, they say, tell me about your riding mower. Tell me who in your family is important to you. Tell me the things that you need to be able to do in order to make whatever pile of interventions I need to know about worth it to you. I'm really glad that we have that it gives us the language to sort of help bring the rest of our colleagues along who are sort of looking at this as we can just give medications and that works on symptoms. No, focusing on the patient's quality of life, medications are part of it, but these other pieces are just as crucial. And it really gives us that opportunity to kind of highlight that.
Thank you both. I really appreciate that. As the daughter who is now being taught all of those things like the riding mower, how to fix the sprinkler heads and all of those things. It is the joy, though, that gets me, to work with my dad and make sure those what matter things are important. And we've come to probably a peaceful understanding about when you can get on a ladder and when you can't get on a ladder. And at least doing it when there are others in the household seems to be the place we've come to.
If you're me, you can never get on the ladder.
To agreement on. So, yeah, thank you for that. And thank you for the support and alignment with Age Friendly. I frequently have said to the audience with Age Friendly is, as I continue to go on that aging journey, I will, be looking for those hospitals and health systems when we're in the motorhome that have those kinds of approaches through it as I become part of that body going forward. So thank you for that. I think that's really important. And we really appreciate your participation in the Next Gen Fellowship and working on Age Friendly there. So thank you. I think we have one last question I'd like to open up to everyone. And then I do see one question in the chat, the last M of the 4 M's. It's what matters, medication, mobility, and mentation. Those are the 4 M's. So thank you for that question. But the last question I just want to do is open up to the panel and really any takeaways that you have that you think are key. Really, maybe 2 or 3 lessons learned from the use of palliative care during COVID, things that you think that the hospitals or healthcare systems that are on the call today could really take as a learning or something to implement and go forward. What are your thoughts? And I just open it up. Anybody can jump in and start with what you're thinking along those lines.
I'm glad to start, Marie. I've just lessons learned from today's discussion, maybe, a couple of aha moments that I had here. As we talked about crisis standards of care and, back when that first started being whispered about as far as a necessary part of the discussion, I think there was a lot of trepidation, a lot of course, concern about public perception and everything. And, the Hippocratic Oath and just tremendous conversations about how difficult it was to get to that point. But I also, as I heard about the skill sets that are necessary for all clinicians to have around palliative care, their awareness of that and their ability to understand that as it applies to the patients they're taking care of. But also, as I think about what a blessing it would have been if we had a broader set of skills with all clinicians and leaders, because I think it would have helped with our resilience and our own mental health and the issues that we're going to see for, I think, years to come as we deal with the PTSD and other after effects of this crisis. So, palliative care skills, don't solve the problem, but they certainly help you frame the problems. And I think that has a lot of crossover impacts that we need to explore further. And then, the strategic placement of palliative care clinicians along the longitudinal continuum of care and how to integrate that into building the care model of the future, because we turn to that in the fact that we're going to have a significant shortage of workforce for years to come. And how do we create the most efficient care model, whether it's acute care or in the doctor's office or in the community or in the home or wherever it is along that longitude? What skills do we need to be integrating there, and especially as we deal with those with serious illnesses? So those are my two takeaways from today that I really appreciate.
That's great, Michelle. Thank you. And I love putting those pieces together. I think it's so important. And doing my best to recruit the nurse of the future in my niece this weekend at school. So trying. Other thoughts, lessons learned, key takeaways?
Three things, I guess I'll go next. The first, and this is what I heard from health system leadership over and over, that palliative care within the Mount Sinai health system went from a nice to have to a necessary to have. That the crisis of COVID really pointed out how integral and necessary it was for the health system. The second thing that we learned, and this was both palliative care and across the health system, is how deeply entrenched the inequities are in our healthcare system. And that it really mattered what the color of your skin was, and it really mattered where you lived, how you did. And then I think the third, which has made me a little bit controversial recently, but it confirmed for me how irrelevant advanced care planning is. And in fact, how dangerous it was. We saw so many people coming through who, quote unquote, had an advance directive or engaged in advanced care planning with their clinician or had a medical order for life-sustaining treatment, had absolutely no idea what it said, had absolutely no idea what they were talking about. And the crisis of the moment saw too many doctors who took these documents at face value and didn't have a conversation with their patients. And it really pointed out to me how ineffectual this process were and how it is so important to actually be able to train people to have in the moment goals of care conversations when things really matter, when they're not hypothetical. We just saw so many people change their mind when they actually heard what was going to happen in both directions, opting for intensive care or opting not for intensive care. And it had no correlation or relationship to the conversation they had umpteen years with their family in the past. And if it ever pointed out to me the disconnect between the hypothetical of advanced care planning and the reality of complicated decision making in the setting of serious illness, COVID was it.
That's a really amazing insight. Thank you for that. Other thoughts?
Yeah, I would love to spend a minute with Sean's other point about equity, see if I can sort of position a national focus on health equity within a conversation about palliative care and serious illness. Because, of course, Sean's absolutely right. You can't talk about the pandemic without talking about equity and the enormous disparities that were, neon sign pointed out during the pandemic. If you're thinking about racial and ethnic disparities, as opposed to, for example, geographic or socioeconomic, Black and Brown patients with serious illness do have worse experiences and often worse outcomes than white counterpoints. And what those disparate sources of suffering look like by the numbers, by the published evidence, is poorer quality communication with clinicians or not being asked about care preferences, symptoms not being acknowledged or addressed, outsized caregiver burden. And I think, those sources of suffering are stock and trade issues for palliative care teams who are expert at really understanding what's going on with the person's life. The foundational tenet of palliative care is looking at each patient as an individual with a constellation of factors driving that experience of illness, and structural racism is one of them. So I don't mean to suggest that palliative care teams are going to address health equity issues for patients with serious illness, but I think that palliative care as a field has a big role to play in addressing that outsized suffering. So that's number one. And number two, Michelle, I really appreciated what you said about thinking about the interplay between where and how specialty palliative care teams are able to serve patients, and what to think about that organizational strategy. And I think of it really as a three-legged stool. So there's specialty palliative care teams who are needed inside of the hospital walls and in community settings, in ambulatory clinics, visiting homebound patients. Telehealth services can help extend that capacity, particularly in the context of a limited workforce, as Sean said, either geographic capacity or frequency of touch points with patients to understand what's going on and prevent crises. And then that third leg of the stool is really raising the bar on what we consider to be in scope for every clinician that touches a patient with serious illness in terms of palliative care practices and principles. And that's where we get into the education and sort of systemic supports that would allow clinicians who are trained to have a goals of care conversation actually spend the time having that conversation and documenting it. The context of the pandemic here is very different than it will be post-pandemic. But I think all three of those things are important considerations for hospitals and health systems. And all three of those things, to wrap it up, seem to me like important components of age-friendly healthcare. So those are my thoughts.
Thank you, Brynn. Appreciate those connections. And then Dr. Noreika?
Thank you. The two pieces I think I would add to it is, and to Sean's point, yes, misadventures in advanced care planning. I think, though, it does point to the time that you spend on your system. And we've mentioned this in some degree, where we've all decided there's never going to be enough palliative care providers. There's workforce-wise, or we can't pay them wise, or a whole lot of things wise. So how are we going to put a system in place that not only supports the palliative care clinicians, right, but also actually supports all the other team members? If I go around the hospital and I look at moral distress, a lot of it is the absolute lack of education experience for both. And, I mentioned before I was in the military, and one of the things I sort of learned thereafter is that a lot of the things that we did in training was just sort of to tolerize me to the fact if I wasn't familiar with something, that I wasn't going to panic. So they just kept, locking me in burning rooms and sinking ships and what have you. And eventually you sort of are like, okay, well, I guess I'll just adapt to everything. But I think, one of the things we all kind of got out of this experience was, and we're all tired now, so the resilience doesn't feel like it's there, but I encourage everybody to keep checking over the next 6 to 12 months, and you're going to find things there that weren't there before, and use those things, because we are going to need them to build a system that's different. It's going to take a ton of energy, and everyone here has referred to it. The way we practice serious illness care currently in the United States is not sustainable and doesn't get us to the outcomes we want. So how are we going to work together to do this differently? And if we agree that differently is almost sort of down to the foundation, well, now we all got to roll up our sleeves and get in there and kind of rebuild this the way it needs to be, not only for our patients and families, but for all of us too, right? Because the last point I'll make to, we talked about the 4 M's and what matters most. And I would sort of offer to you, and what I've been offering to sort of our house staff here, is that's for you too. As you go through your career in medicine, and it'll change over time, right? But as you go through your career in medicine, and it's not always possible, I'm not, trying to be Pollyanna over here, but the more you can align yourself with work that you say, I feel the value in this, the more that it's going to be kind of, and you've sat with these patients, right? You've sat with patients at end of life, you know this already. Those are the things that people reflect back on. Those are the experiences. That's the stuff that folks hold on to when they're sort of reviewing their lives. So I encourage everyone, it's not just for our patients and families what matters most, it's also for us.
Thank you, Dr. Noreika. That's an awesome place for us to land on those lessons learned, and certainly one that we can help each other by reminding each other. And those self-care, we started a chat before this panel discussion started, and there was some conversation in there about self-care. So, and it had to do with music and the outdoors. So, important to integrate into this conversation. we have a few minutes left, and I have a couple of questions that were submitted prior to the panel, and I'd like to go ahead and start with one of those questions. And Michelle, I'm going to direct this one to you. It says, senior leaders see value in palliative care, but finances are still so tight in many areas that funding is difficult. When will we reach the tipping point where we can stop constantly trying to justify the financial investment in palliative care?
Wow, that's not an easy answer, is it? I don't know exactly the tipping point, but I will say, just first of all, our healthcare system is in tremendous financial distress right now. About a third of the U.S. hospitals will finish 2021 with a negative operating margin. And while most of those will be making up for that negative operating margin with their earnings on their investments, on their balance sheet, that's not a sustainable place to be. And we are constantly receiving bad news from the payer side of the equation. So just late last week, for example, Congress built into the bill that's being debated right now on social infrastructure, the reconciliation bill, a pay for that included a significant Medicaid dish cut, which has to be then made up for someplace else. So the CFOs and the COOs and the CEOs are taking it constantly as payers fight to keep every penny that they can possibly keep, including commercial payers who introduce things like unrealistic utilization review practices or the constant cycle of denial management that adds administrative burden to the system and so forth. So, one of the questions, two things is that I think of when I think about the tipping point is, one, when is the payment model going to significantly change so that we are not playing the kind of cycle of change that we have become accustomed to, where every year you start the year and you don't know what your payment's going to be. When I talk to boards, I say things like, a lot of you are small business people or large business people, and if your major payment source could change the way that they pay you without any consideration every year, or sometimes more often than once a year, how would you make your business model work? So the payment model is going to have to significantly change, whether we introduce capitation for primary care and really make significant change in the way the revenue streams work. And the other is, we've got to take some of this onto ourselves, because the productivity of our healthcare delivery system has not improved. Even with all the investments we've made in technology, we are lagging all other fields in the country as far as demonstrating improved productivity. Academics might be behind us, higher academics in particular. We're a very labor-intensive business model, and we've got to figure out how to increase the efficiency and productivity so that we have a little bit more elasticity in our financial equations. Is this the time where we've finally been pushed to the point where we're willing and maybe even incentivized to make those changes? There's a growing number of leaders in the field that believe it is, but I still think we have years ahead of us before we have the transformation that we're all hoping for.
Thank you, Michelle. I love the comment on productivity. As a performance improvement person who had a lot of experience working on productivity in my past, I think that is something that is really important for us to look at and pay attention. That effective and efficient practice is definitely something we need to work on. So thank you for that. And Brynn, I know that just along those lines, I know CAPC has resources that help with calculating return on investment or the financial piece. I just offer an opportunity if you want to speak to any of those resources, or just let people know where they can find those, if that's useful.
Yeah, we do. And I'm thinking we can maybe put some of those in the chat as well. But on our website, we have what's called the Hospital Impact Calculator for palliative care. And what it lets you do is, based on, again, the evidence-based about the financial impact of palliative care, consult services, model what it would look like to grow the size of your palliative care team in order to reach a larger proportion of patients in the hospital. And so we'll post a link to that. We've also put together a kind of a resource for those on the line who were interested in this conversation and want to keep thinking about it for 3 actions you might be able to take tomorrow to start thinking about palliative care potential.
Thank you, Brynn. Appreciate that. I know as a clinician who frequently got asked to show the financial case, that's when I went back and got my MBA. So those kinds of resources are always helpful, Brynn, and those tools really make it a little easier. If you have to keep telling the story, you might as well do it with a good tool or resource that helps that. So appreciate that. If you want to learn more about joining the AHA Living Learning Network, you got a sense of what we do in that Living Learning Network today. It is an amazing group led by the AHA team, really great group of people. They would be happy to share information, answer any questions you might have. Thank you all so much for participating in this. And as I said, I have just pages of notes here, and so exciting to hear the thoughts and the direction that it seems the field may go on this. It's time to bring palliative care all into everything that we do and those what matter conversations. As I was listening to Dr. Morrison and his thoughts about those advanced directives, it just reminded me of how many times my father has been resuscitated on a ventilator and, has gone through all those things. And he was willing to go through those things thinking, that they would make his life such that he could keep getting on that lawnmower. And so those conversations around what matters are not just, yes, I want to be resuscitated. No, I don't. They're really around what is important to you in life. And will this help you do that down the road? So I think that's a real distinction that sometimes our conversations don't capture those things. And it just reminded me today of that on a personal level. So thank you so much for sharing that. Appreciate all of the time and effort folks have put into this. Any needs you have regarding the LLN, please reach out to the team, and we would love to see you in more events that we share going forward. Thanks, everybody.
The views and opinions expressed here do not necessarily reflect the official position or policy of the CDC. Involvement of CDC should not be viewed as an endorsement of any entity or individual involved.